Hello, everyone. My name is Octavio Pontes. I am a neurologist and associate professor of neurology at Ribeirão Preto Medical School, University of São Paulo. I'm also the editor-in-chief of the World Stroke Academy. And it's my great pleasure to be here today to interview Professor Bruce Neal, who is the director of the executive director of the George Institute of Global Health in Australia and professor of medicine of the University of South Wales in Sydney. And it's also one of the main authors of a very interesting paper that was just published in JAMA Cardiology, the SUS study, the cluster randomized trial that was conducted in China to test whether replacing regular salt with salt substitute could decrease the recurrence of stroke. And we are very excited to have you with us here today. Bruce, thank you so much for your availability.
Thanks, it's a pleasure to be here.
Yes. So Bruce, just to start, could you please tell us a little bit about what is the state of the evidence right now to incorporate salt substitutes in the diet all over the globe?
Yeah, so we've got pretty good evidence now. There's data from about 25 or so randomized trials. Only two of them are sort of more than 1,000 or so people. One of them was very large, which was the study that you mentioned that we did in China, which was about 21,000 people. But there's data on more than 30,000 people, and it shows very clearly that if you switch regular salt for a potassium-enriched salt, so a salt in which some of the sodium chloride has been switched out for potassium chloride, then you will lower blood pressure, and you will also lower the risks of stroke, cardiovascular events, and also premature death. The challenge with the data is that much of the research has been done in a few countries, China and East Asia in particular, and much of it has been done in clinical populations with vascular disease or with hypertension. So while it's very likely that salt substitute will also lower blood pressure in many other groups of people, we don't have the same direct evidence that we do for those subsets.
Okay. So in terms of the results, can you summarize the main results of the study that was published in JAMA Cardiology recently for us?
Yeah, for sure. So basically, this was a secondary analysis of the salt substitute stroke study, which was first published in its entirety back in 2021. And what this secondary analysis did, and it was done by colleagues based in China, was they just picked out the 15,000 or so about 3/4 of the participants in the original trial had a stroke at baseline. And they did a secondary analysis to really try to answer the very specific question of, does salt substitute prevent recurrent stroke? And I think the idea there was that if you could provide good evidence about this, it would be a really helpful piece of information for people who are caring for this very high-risk set of individuals. So what they showed was actually very similar to what we showed in the main study, which was that, yes, if you switch regular salt for potassium-enriched salt, you lower systolic blood pressure, and you also lower the risk of recurrent stroke. And you lower the risk of recurrent stroke by about the amount you would expect for the blood pressure reduction you got. And we saw also that you got greater reductions in the risk of hemorrhagic stroke than ischemic stroke, which again, of course, is what you would expect for an intervention that is acting through blood pressure lowering.
Okay, great. So we have recently seen a publication from the World Health Organization, a guideline recommending salt substitutes as a way to reduce the risk of cardiovascular disease and cardiovascular outcomes. Could you comment on the importance of these guidelines and what are the main challenges that we have now to implement this kind of approach all over the globe?
Yeah, so to have the World Health Organization put out a guideline on this topic is obviously huge in terms of potential impact and implementation. And what the World Health Organization guideline sort of specifically says is if you're thinking about using salt to season food or to cook in the home, then you should switch to a lower sodium salt with added potassium. Now, that's great. But the question is, did it go as far as it could, I think, because what it very explicitly doesn't include is salt that is in processed or packaged foods. And, you know, as the world transitions to a diet that is based much more on foods that you buy pre-prepared from supermarkets or from restaurants, that salt is really important. And, you know, fair enough, there wasn't direct evidence that replacing salt in food versus salt that you add to season or add to recipes at home, but the likelihood that that's not also going to be a really beneficial thing to do is pretty small. So that's particularly important for countries that are more developed, where most of the salt is that sort of so-called non-discretionary salt. Although, to give the guideline credit, for 3/4 or so of the world, most of the salt that is consumed comes from that discretionary salt added at home while cooking or seasoning. So the guideline is highly relevant to the majority of people.
Okay. And then I have a final question I would like you to comment on about the safety of this approach in terms of the risk of hyperkalemia. And how can what precautions should be taken to prevent hyperkalemic in high-risk patients if these salt substitutes are widely adopted all over the globe?
Yeah, so this was also a big feature of the WHO guideline, and there was clearly considerable concern about the potential for causing harm in some people. Now, as you point out, the people who are going to be at risk are people with kidney disease, frankly, probably people with moderately advanced kidney disease, because it's not until you get moderately advanced kidney disease that you really struggle to manage potassium levels in the blood. Obviously, if you know you've got kidney disease, then that's fine, because people with kidney disease are recommended to avoid potassium and to avoid foods that are high in potassium. The real concern is if you've got countries, say, where if you implemented a nationwide switch to potassium-enriched salt, there might be people in the community who would have undiagnosed serious kidney disease who could get harm. Now, it's clearly possible. Interestingly, there have been a couple of substantive modeling studies that have been done, which have tried to weigh up the likely balance of risks and benefits. And what they find is that even in people with kidney disease, you would likely get net benefit, because people with kidney disease are so likely to have a stroke or a heart attack that could be prevented. So the benefits of the blood pressure lowering would trade off against the potential harms of hyperkalemia. I should say also that none of the trials completed to date have actually showed any adverse effect on hyperkalemia, though they've all taken some effort to exclude people who might be at risk. Yeah.
All right. Well, Bruce, thank you so much for your time, and I think it's been very helpful to interpret the results and the state of the art in the field, and I hope we can move forward with this agenda. And I know that you are a champion about salt substitutes, and I hope we can help to include more people in the widespread use of this important approach to reduce the risk of cardiovascular disease in the future. Okay,
Yeah,
thank you
thanks,
so much.
Octavio.
Bye-bye.
Bye-bye.